Hello everyone, I'm Dr. ASHIS Majumdar here to present a rare case of brittle cornea syndrome, 1 in a million case. A 9-year-old female patient has come with a chief complaint of gradual dimness of vision in both eyes from the childhood. With frequent change in spectacle, she has also complained with photophobia, blurring and ghosting of the object. Uncorrected visual acuity of right eye is finger counting 1 feet and in left eye it is finger counting 2 feet, whereas best corrected visual acuity is 660 in both eye. On slit lamp examination, we have seen blue sclera, horizontal nystagmus in both eye, thinning of the cornea, central corneal opacity, and Munson sign was positive. She has also shown Vox stria, prominent corneal nerve, and Fleischer ring in both eye. Though the fundus examination was a bit blurry image we got due to nystagmus and astigmatism, but here we can see the tessellated fundus, tilted disc, and myopic crescent in both eye, which is suggestive of pathological myopia. The tomography has shown that the thinnest local point of the right eye, the pachymetry was 384 micron and in left eye is 373 micron. After ophthalmic examination, her auditory system examination shows the moderate to severe sensorineural deafness with sloping pure tone audiogram. On musculoskeletal examinations, she shows long, slender extremities, hallus valgus, loose skin and hyperextensibility of small joints suggestive of Ehlers-Danlos syndrome. She has also presented with umbilical hernia of 21 into 16 millimeter gap in anterior abdominal wall with mild tricuspid regurgitation, and she also had a history of convulsion in childhood and history of delayed motor development. So and she has a history of consanguineous marriage between her mother and father. So from here, the provisional diagnosis is come to a rare case of brittle cornea syndrome. Now we needed to do a confirmatory test. For that, we have done one genetic sequencing test, which shows homozygous autosomal recessive pathogenic mutation in PRDM5 gene, which is suggestive of brittle cornea syndrome type 2. For this patient, as she does not have any kind of rupture or very pathological any problem, so we plan to go for medical management and visual rehabilitation. For that, we had done refraction and glasses has been prescribed. Protective polycarbonate glass and contact sports has been avoided. According to Bright et al., it has been shown that there are two kinds of brittle cornea syndrome. One is BCS1 and BCS2. In brittle cornea syndrome 1, there is zinc finger mutation, and in BCS2, there is PRDM5 mutation. But in BCS2, there are various variations. This is variant number 1 because she has homozygous mutation with no corneal rupture. There is myopia, keratoconus and blue sclera. She also have abnormal scarring of cornea. She had small joint hypermobility. She had hernia. She had deafness, and her CCT in both eye was less than 400 micron. So my question to the chairpersons are, as this patient is gradually thinning her corneal thickness, so I am very much scared that she might have a corneal rupture in very recent days. Though there are various literature, those who have shown that there are suturing with 11O nylon sutures and or like lamellar keratoplasty. What should you suggest to do in this case? Thank you.
I would wait and watch, and if needed, I'll go for a surgical treatment.
So what surgery do you prefer, sir, in this case?
That's the perforation or an inverting perforation. On extreme thinning, I would prefer keratoplasty.
Is there any special care we should take for this case?
No, but pediatric keratoplasties are always special, we need to take utmost care. Projection component is low, and they are special cases, but risk and the benefit, I would definitely watch, and if
Thank
Sir,
you, sir.
any role that you think for corneal cross-linking in these patients?
The picture what you showed,
That is showing already scarring. In this case, yeah, in this case it would probably not be the case. But in case there's no scarring, then would you consider for cross-linking?
cross-linking is a good option for all ectasias. Cross-linking should be the primary option, but
In this
certain
case,
amount of
obviously.
thinning and
Yeah.
scarring, I wouldn't think about
So
cross-linking.
just an experience, just last month I had a case of brittle cornea syndrome referred from outside, 12-year-old kid. Both eye twice operated graft, one eye in phthisis, other eye also a failed graft with RD. So obviously the prognosis with these patients is not really good. Even with the best of efforts, a lot of patients do end up being blind. So we did a K-Pro VR and a keratoplasty for that patient, did rehabilitate, but obviously the life of these kids are really compromised.
So what K-Pro you have tried?
We
for
did a
this?
temporary K-Pro with VR and an optical keratoplasty in that patient.
Thank you. Thank you.
Very challenging and interesting sort of a syndromic case that you brought out. So as Pranita also mentioned that these children most of the time realize, the family realizes there's a problem when they come in with some minor injury. So there's a perforation after minor injury. And when you're dealing with the case, that's when you realize or you've seen the patient preoperatively. Because it's difficult to examine the eye, but you have to, and this is very well sort of physical, the phenotype was very typical. Sometimes you may have a little variation in that. So you have to watch out for a child who has such a bad glow perforation after trivial trauma. So like we pointed out. So this child is always at risk, even a very forceful Valsalva maneuver or anything of that sort. Very minor injury. So we had a patient who, the mother was combing the hair of the child, just combing the hair with a comb, and that's what injured the eye. So even very trivial injury can damage the eye and there will be large perforation. So again, just like you said, for this particular case, because the pachymetry, as per what you saw,
Yes.
is not as thin. But
Yes.
if it's thinner than this, then and you know you take the risk and benefit. So if you leave the child alone, then it's likely to perforate, and then you have to do an emergency situation kind of. So if at least for one eye, if you want to visually rehabilitate, what we do is like an epicatoplasty with a sort of a, you can't even do much of peripheral tucking because even the sclera is not healthy through the little cornea, so it's difficult to suture. But saving the stem cells, just a little bit of peripheral dissection and tucking in the flange in there, and that can work. We've had success over there, but again, it has its multiple problems, as you said, including glaucoma, rejection, epithelial ingrowth, and so on.
Ma'am, will tuck-in lamellar keratoplasty will help in this case?
Maybe.
So it's again difficult to tuck it in because of the sclera also being abnormal. So we have to see case to case whether it is possible or not. The reason to tuck it in is because of being such a large keratoplasty. You want to protect the stem cells, you don't want to excise or suture on top of that, and you want to stabilize the graft that you want to put in there.
Thank you.
Optical keratoplasty means it's too much of the opacity is there, scarring is there, and so much of thinning is there. So we can wait and watch, as Sir has said, by keeping the BCL for some time, and then optical keratoplasty is the choice.
Thank you, sir.
Yeah.
So I had a case fairly recently, maybe 6 months ago, where the child came similar with trauma, and the parents just didn't realize that the child has so many other problems, including also had systemic problem, like your case had cardiac issues. So did our child, and so I had to take a 14 millimeter graft because there was a complete perforation. In fact, the perforation was literally at the limbus. It was running about 270 degrees. From one end, it had just ripped across, going to the other end. So I actually took a smaller size graft, and when I was suturing, I realized that this is not going to work. So I had to literally just sacrifice the tissue, and again remeasure and take a bigger graft. And it took me 2 or 3 hours to finish that case. So that child, because we used a very good optical quality tissue, so the child is doing okay. But as Dr. Lionel Raj mentioned, that it's a very tough, challenging situation for pediatric patients.
Thank you.